What I'm about to explain is one of the simplest, most overlooked conversations you can have with your doctor about blood pressure, and yet it touches on some of the most complex rhythms inside the human body. In clinical practice, there are moments when the solution is not a new drug, not a higher dose, and not another restriction added to a patient's life. Sometimes the intervention is timing, not because timing is a gimmick, but because biology itself runs on time. There is a growing body of research in chronobiology, the science of how the body functions across a 24-hour cycle, showing that when medication is taken can be just as important as what medication is taken. This is particularly true for blood pressure. Before going further, it's important to be absolutely clear. No one should change when they take prescribed medication without first speaking to their doctor. The goal here is not to replace medical advice, but to help you have a more informed, precise, and productive discussion with the person who knows your medical history best. Your blood pressure is not a fixed number, it is dynamic, constantly adjusting to internal and external signals throughout the day. In healthy individuals, blood pressure follows a circadian rhythm. It rises in the morning, fluctuates during the day, and then drops at night during sleep. This nighttime drop, typically around 10 to 20%, is known as the nocturnal dip. This dip is not optional, it is essential. It allows the cardiovascular system, the kidneys, and the brain to recover from the constant workload of daytime function. Well, however, in many individuals, especially those over 60, this dip is reduced or disappears entirely. These individuals are often referred to in clinical literature as non-dippers. Studies suggest that up to 40 to 50% of older adults fall into this category. The implications are significant. Non-dipping is associated with increased risk of stroke, heart failure, kidney disease, and cognitive decline. At the same time, there is another pattern that is equally important: the early morning surge. Between approximately 4 a.m. and 10 a.m., the body undergoes a coordinated physiological shift. Cortisol levels rise, sympathetic nervous system activity increases, blood vessels constrict, platelet activity rises, making blood more prone to clotting. Heart rate and blood pressure both increase. This is not a malfunction. It is part of the body's preparation for waking and activity. However, this same surge is also associated with a disproportionate number of cardiovascular events. Epidemiological data has consistently shown that heart attacks, strokes, and sudden cardiac deaths occur more frequently during these early morning hours. Now consider the timing of medication. Many blood pressure medications, especially those taken once daily, have pharmacokinetic profiles that peak several hours after ingestion and gradually decline afterward. If a medication is taken in the morning, its peak effect often occurs in the early afternoon, with diminishing levels overnight and into the early morning. This creates a potential mismatch. The period when the body is most vulnerable may coincide with the period when medication levels are at their lowest. And this observation has led to the concept of chronotherapy, aligning medication timing with the body's biological rhythms to maximize effectiveness and minimize risk. One of the most widely discussed studies in this area is the Hygia chronotherapy trial, published in 2020. This large-scale study followed over 19,000 patients with hypertension over several years. Participants were randomized to take their antihypertensive medication either in the morning or at bedtime. The results were striking. The bedtime group showed significantly lower rates of cardiovascular events, including heart attacks, strokes, and cardiovascular mortality. However, science rarely speaks with a single voice. The time trial conducted in the United Kingdom and published later were included over 21,000 participants and found no significant difference in major cardiovascular outcomes between morning and evening dosing. How should this be interpreted? First, both studies agree on an important point. Taking blood pressure medication in the evening is generally safe for many patients. Second, the difference in outcomes may reflect variations in study design, patient populations, adherence, and other factors that are still being analyzed. Third, and perhaps most importantly, both studies reinforce the idea that timing matters, but it is not one size fits all. Different classes of blood pressure medications behave differently. ACE inhibitors, such as lisinopril and ramipril, and angiotensin receptor blockers, ARBs, such as losartan and valsartan, when act on hormonal systems that are particularly active during the night and early morning. Calcium channel blockers, such as amlodipine, also provide sustained vascular relaxation that may be beneficial when aligned with nighttime physiology. For these medications, some clinicians consider evening dosing in appropriate patients, especially those with evidence of non-dipping or elevated morning blood pressure. On the other hand, diuretics, commonly known as water pills, increase urine production. Taking them at night can lead to frequent nighttime urination, disrupted sleep, and increased risk of falls, particularly in older adults. For these medications, morning or late afternoon dosing is usually preferred. Beta blockers, which reduce heart rate and myocardial workload, require more individualized consideration. Because heart rate naturally decreases during sleep, taking certain beta blockers at night may lead to excessive slowing in some patients. This decision should always be guided by a physician. What does this mean in practical terms? It means that if you are taking medication for blood pressure and you notice that your morning readings are consistently higher than your afternoon or evening readings, this is a meaningful observation. It does not automatically mean your medication is failing, but it does suggest that your current regimen may not be optimally aligned with your body's rhythm. One of the most effective ways to explore this is through home monitoring. Taking blood pressure readings at different times of day, especially shortly after waking and again in the afternoon, can reveal patterns that a single clinic measurement cannot capture. In some cases, doctors may recommend 24-hour ambulatory blood pressure monitoring, which provides a detailed picture of how blood pressure behaves during both waking and sleeping hours. Armed with this information, the conversation with your doctor becomes more precise. A reasonable way to begin might be, "I've noticed that my blood pressure readings in the morning are higher than later in the day. Could this mean my medication is wearing off overnight? Would it be appropriate to consider adjusting the timing?" This approach is collaborative. It does not assume a solution. It opens a discussion. Beyond medication timing, there are additional factors that influence nighttime blood pressure and the morning surge. Dietary choices in the evening can have measurable effects. Foods high in sodium or certain compounds, such as tyramine found in aged cheeses, can stimulate sympathetic activity in sensitive individuals. While not everyone will respond the same way, being mindful of late evening intake can be helpful. Sleep position and sleep quality also play a role. Conditions such as obstructive sleep apnea are strongly associated with non-dipping and elevated nighttime blood pressure. Even in the absence of diagnosed apnea, poor sleep quality can disrupt the normal nocturnal decline in blood pressure. Fluid intake late at night may lead to nocturia, frequent nighttime urination, which disrupts sleep and can indirectly affect blood pressure regulation. Adjusting fluid timing earlier in the evening is a simple strategy that may improve sleep continuity. Stress exposure in the hours before sleep is another underestimated factor. Exposure to stimulating or distressing content can activate the sympathetic nervous system at a time when the body should be transitioning toward rest. All of these elements interact. Blood pressure is not controlled by a single mechanism. It is the result of a network of physiological systems working in concert. What emerges from this is a broader principle. Effective blood pressure management is not only about lowering numbers, it is about restoring patterns. When the natural rhythm of dipping at night and rising in the morning is preserved, the cardiovascular system operates under less strain. When that rhythm is disrupted, even normal daytime readings may not tell the full story. This is why timing of medication, of meals, of sleep can have disproportionate effects. It is also why individualized care is essential. Two patients with identical clinic readings may have very different 24-hour profiles. One may dip normally at night, the other may remain elevated. One may experience a sharp morning surge, the other may not. The goal is not to apply a universal rule, but to align treatment with the individual's physiology. For some patients, that alignment may include adjusting when medication is taken. For others, it may involve addressing sleep disorders, modifying diet, or optimizing medication type and dose. The key takeaway is not that everyone should take their medication at night. The key takeaway is that timing is a legitimate, evidence-informed variable in treatment, one that is often under-discussed. If you are living with hypertension, the most valuable next step is not to make a change on your own, but to gather information, track your readings, notice patterns, pay attention to how you feel in the early morning compared to later in the day. Bring that information to your doctor. Ask questions. Medicine advances not only through new discoveries, but through better application of what we already know. Sometimes that application is as simple and as powerful as taking the same pill at a different time.